Morning, guys. I'm Alan Lessie. Dr. Lessie, I'm going to be the attending on service today. I understand we got one admission last night. Who's going to be presenting?
Max Diddams, one of the fourth-year medical students.
Okay, Max.
All right.
Very good.
So Mr. J over here is a 75-year-old white male who came in last night after he was found at home. He had profuse maroon diarrhea about 9 p.m. He called an ambulance, was taken to WCA. And prior to that, he'd had about several days of malaise, fatigue, a little bit of decreased appetite. And so when he came into WCA, he had actually some profuse hematochezia as well as hematemesis. And they estimated his fluid losses to be about 2 liters combined. He had a hemoglobin at that time of 11.4, and he got transfused for 2 PRBCs. He also got a 3-liter bolus of normal saline, and they started him on 40 milligrams of pantoprazole and 20 milligrams of furosemide. On top of that, he got a CT just because he was there, and he got, but they found no free air, small bilateral effusions on the lungs, but otherwise normal CT scan. His NG at the time that it was placed drew out about 250 milliliters of coffee grounds-like substance. So then, at that point, he was transferred over to the VA here for just further workup. He has no history of a GI bleed before. His last hospitalization was 4 years ago for fluid overload, and he says he was diuresed successfully, no real issues since then. He does have a history of being on dabigatran for his atrial fibrillation, but he stopped taking it in the last year because it was too expensive. He'd been on warfarin prior, and then when they switched him over there, it worked for a while, but he lost his insurance, and so he couldn't pay for it.
Okay, so he hadn't been on it for the last year?
No, for the last year he has not been on it. However, he does take 1 aspirin a day for his heart, he says, and then he also takes 4 Excedrin a day for knee pain. In addition, he's also drinking 2 beers a day, but sometimes he says he'll drink to the point that he passes out with his friends, so I'm not sure how accurate that actually is. He did have a colonoscopy in 2012, which showed only 1 polyp. Otherwise, his past medical history is significant for CAD, HLD, and AFib. He's got
and those abbreviations are?
And his past medical history is significant for coronary artery disease, hyperlipidemia, atrial fibrillation, hypertension. He also has a primary cardiomyopathy. It's not ischemic. I don't know. They're not really sure what caused it. I think in one of the notes it said viral, but it's possible alcoholic cardiomyopathy. He does have a history of CHF, as mentioned before, sort of an undocumented history of a TIA and some mild sleep apnea. He doesn't have any allergies that we know of, and his past surgical history is only notable for the left knee replacement back in 2003. He's complaining quite a bit about his right knee, and hence why he's taking the Excedrin. Otherwise, his family history is only significant for a mother with coronary artery disease. Socially, he's widowed, he lives alone. He never has smoked, but as we talked about with the alcohol, he's drinking 2 beers a day plus a little bit more on occasions. Never has used any sort of intravenous drug or recreational drug. From a review assistant standpoint, as I mentioned, no fever or chills, no weight loss over the past couple weeks, no chest pain. He does have some palpitations, some shortness of breath, and a cough and a wheeze, and obviously the nausea and the vomiting and the diarrhea that we've talked about with the blood. Otherwise, review of systems has no pertinent positives or negatives. Med-wise, he's taking lisinopril 5 milligrams daily, metoprolol 25 milligrams BID, and pantoprazole 40 milligrams. He takes a baby aspirin daily, the Excedrin as we talked about, and he takes furosemide 40 milligrams BID, though not always. At this point, he only takes it when he feels that he's a little overloaded.
Okay, and the pantoprazole started here, or was he taking that previously?
He was taking that previously at home. I understand.
Oh, okay.
I think he has some GERD, but it's not really documented.
Okay.
Yeah.
And did you get a history from him for how much he's been taking it? Is it frequently? Is he taking it regularly,
He
daily?
says he only takes the lisinopril and the metoprolol daily in addition to the aspirin and the Excedrin. I don't think he takes the pantoprazole daily. For physical examination, he was soft blood pressure, 1/2/65, and a heart rate of 100. We did orthostatics on him, and he was 101/63 for his blood pressure, but he got a little bit tacky to 120. His respirations have been
And let me just stop you there.
Sure.
Why did you do the orthostatics?
we were concerned. He's gotten the boluses at this point. We were worried about hypertension. We're not quite sure how much he's bleeding. It's clear he's bleeding some, so we just wanted to make sure that he wasn't severely dehydrated or hypovolemic, I should say.
Okay. And did you consider those orthostatics to be positive or negative, or did he have orthostasis?
So with the blood pressure, there's not a significant change to call it orthostasis, but he did get tachycardic, which I believe is the indication for positive orthostasis.
Yeah, I mean, which one do you think you're going to maintain, what your body's going to try and maintain, your heart rate or your blood pressure?
Well, obviously the blood pressure is a
Right.
little more important.
Yeah, and so he'll go ahead and increase his stroke volume, or increase his rate and his cardiac output to try and maintain his blood pressure. So in that case, he did have, evidence of orthostasis. So I'd say that he had positive orthostatic findings.
Otherwise, respirations were 20. He doesn't have a temperature. He's 37. He's 68 inches, 272 pounds, and gives him a BMI of 41. Overall, he's an overweight, diaphoretic male. Doesn't have, for pertinent positives on HNT, only doesn't have any JVD. He's got normal respirations, but on auscultation, he does have crackles, wheezes, and rhonchi. Primarily,
And where are those?
going up about, I'd say about 2/3 up the posterior lung fields, most noticeable in the bases. He's irregular on cardiac auscultation, irregular, but there are no murmurs, rubs, or gallops. His abdomen is soft, non-tender, non-distended, does have normal bowel sounds, and he does have a positive FOBT.
And just for clarity for the other people around, FOBT?
Yes, and so he does have a positive fecal occult blood test. Cranial nerves 2 through 12 were grossly intact, and there are no focal deficits in sensory or motor function. He has normal mood and affect, and he is alert and oriented by 3 times. From a laboratory perspective, a white blood cell count is 16, hemoglobin is 13.1, hematocrit 39, platelets 180.
One more time, the hemoglobin?
His hemoglobin is 13.1, hematocrit 39, and platelets 189. Electrolytes, sodium 145, potassium 5.2, chloride 109, bicarb 34, BUN 44, creatinine 1.16, and his glucose is 136. Troponins were drawn. In the ER, they were undetectable, less than 0.02. His BNP was 112, and his UA was within normal limits. Isonos, as reported up till now, have been 2,260 milliliters in and 4.1 liters out. As I mentioned, for imaging, he did get the CT scan, which showed no free air, some bilateral effusions, but otherwise normal, and a chest X-ray did show some bilateral consolidation there. Pardon me. The chest X-ray showed bilateral pulmonary edema, just in the lower bases primarily. So for assessment and plan for this fine gentleman, he is a 75-year-old white male who's been admitted with a history of CHF, atrial fibrillation, and chronic alcohol use, presenting with an upper GI bleed. He got 2 units of the PRBCs, and otherwise is hemodynamically stable at this point. GI has been consulted at this point. I probably shouldn't mention that later on. For his acute GI bleed, it's going to be likely an upper GI bleed as a result of his drinking and use of NSAIDs. We've got varices as a possible history, but the CT didn't show cirrhosis, so probably less likely at this point. We've got.
And why do you think it's going to be upper? There's a couple findings that would be significant. Why do you think this is an upper bleed?
Obviously, the NG draw that found the coffee ground contents, the hematemesis would be more indicative. The fact that he had frank blood in his stool would maybe argue for a lower, but the NG findings would probably argue for an upper, in addition to the NSAID use and the drinking history.
Okay. And there was something in his physical exam that didn't really fit with that story. What would that be? Any ideas? What part of his physical exam?
Maybe the normal bowel sounds
Yeah,
at this point. I
exactly. Yeah, because I mean, I would really expect him if he's got bright red blood per rectum and he's having an upper GI bleed, he's going to have massive rapid transit time. And so I would think that, you know, he would have had markedly increased bowel sounds. It's one of the, you know, major cathartic agents. So. All right.
Blood in the stool. Gotcha. I don't know what to say to that really. But at this point, as I mentioned, we found the coffee ground output on NG. We've got him transfused two units from the outside facility, and at this point we've got his NG still placed to wall suction. We've got 2 large bore IVs. I think they're 2 16 gauges right now, just ready if we do need to transfuse further. He's been type and screened, and we're ready with more. I think we have 2 units on hold if we need to transfuse him. We're going to continue to monitor him, trend his hemoglobin hematocrit every 6 hours. And otherwise, he's just on the pantoprazole, 40 milligrams IV twice a day right now, and GI has been consulted, and they're going to either see him for endoscopy today or tomorrow. Since he's looking kind of stable right now, they didn't want to move on it right away, but they definitely want to see him for endoscopy.
Okay, but they know about him and they're fully aware,
They do.
and the fellow's going to see him today?
Yes, we updated them prior. Besides his GI bleed, his atrial fibrillation, his CHADS VAS score, as we calculated it, was 6, so he's a high risk for embolism at this point, and he's not being anticoagulated. I mean, the aspirin counts for something, but it's not really considered sufficient for this level of risk. He'd been, as I mentioned previously, on the dabigatran, but not taking it. At this point, we're not going to give him any sort of anticoagulation, obviously, because he's bleeding, but we're going to also hold his beta blocker, given his hypotension and risk for further volume loss at this point.
Now, just out of curiosity, let's say this guy really did have both a GI bleed and you had a documented pulmonary embolus. Okay, so it's sort of just changing the things around here to see. I mean, because we do run into those patients. Is there anything that can you anticoagulate somebody who's got an acute GI bleed?
Anticoagulate somebody who has acute GI bleed. Obviously, we want to be very careful. I'm not entirely sure what you would want in that sort of case. I've heard of doing IVC filters in that sort of context, but would that be something that you'd want to do in that case, an intravascular procedure with somebody who's anticoagulated?
Yeah, at
I'd
least.
have to look that up.
Yeah, I think if you actually had a documented pulmonary embolus, and you probably what test would you do to document the pulmonary embolus?
To document it, like just a CT with contrast, or?
Actually, you need to order a more specific CT scan. Which one?
I'm not sure.
Any ideas which CT?
CT angiogram?
CT angio, yeah. So you don't want to just order a lung CT or a CT. You need to get the rule out pulmonary embolism protocol and get a CT with CT angio to document it. And so if he actually had an embolus, then you probably would want to try and prevent other embolic events, and a IVC filter would be the way to go. And I would talk with vascular surgery. When I was in school like you, which was a very long time ago, we used a lot more of those, and we didn't really think too much about the complications. These days, we're a little bit more careful with them, and we know that people can embolize off the backside. So. All right.
So yeah, I guess the last couple problems really are going to be his acute on chronic heart failure. At this point, just with some of the physical findings that we're seeing of the lower lung fields with the crackles and the chest X-ray findings and his history of CHF. He did get his 3 liters at this point, plus the 2 units, so he's gotten pumped up a bit on fluids. And he's saturating well. Right now, he's saturating 93% on 3 liters of oxygen on nasal cannula. And he has diffuse, as I mentioned, we talked about the physical exam findings. We don't have an echo at this point on file. We ordered one to try and see what's going on there. He says his EF is low, but he doesn't know exactly how low or anything like that. So.
And then once again, we have some difference between the laboratory findings and the patient. What lab finding is unusual in him given his fluid and transfusions and things?
Right. Well, obviously, we'd expect, given a CHF patient, that his BNP would be significantly elevated. But with only 100, I believe the cutoff's 500 to really start saying anything more, be able to say anything more concrete. But in his case, it's low. But clinically, we find him to be fluid overloaded. So at this point, he has received 600 milligrams of furosemide so far. I think we're just going to hold off on it because he's making good urine. If he needs more diuresis, if he becomes edematous or anything like that, or if the chest x-ray is not clearing up, we can probably go ahead and give him more. But at this point, I think we'll just watch him. Because of his little bit of cough and a little bit of perceived wheezing, we did order some albuterol nebulizers, PRN. He got one. He said that improved somewhat. It's not around the clock at this point, but it does make him feel better. And then lastly, just because he does have an alcohol history, we just put him on the CEWA protocol with some thiamine and folate supplementation, and we'll just watch that if need be. Otherwise, he's a full code. GI will see him tomorrow. If not tonight, we'll keep an eye on him and take him through all this.
All right. Well, let's go in and take a look at him, and then we can see how he's doing.
Sure.
All right.
Sounds good.
Good.